Good afternoon, everybody. I'm David Mouche, supervisor for LHSC. Before we begin today's session, I want to pass it over to Tanya Testa, who's going to do our land acknowledgement. Tanya?
Good afternoon. I am pleased to offer today's land acknowledgement. Victoria University and Children's Hospitals are situated on the traditional territories of the Anishinaabeg, Haudenosaunee, Lenapehouk, and Chinootan nations on lands connected with the London Township and Sombre Treaties of 1796 and the Dish with One Spoon Covenant Wampum. I would like to acknowledge that I remain committed to continuing my journey of learning by listening to the stories and experiences of Indigenous peoples in Canada and discovering more about how I can better serve the needs of this population as a leader within a healthcare organization. I would like to give thanks to the stewards of this land and acknowledge the benefits that we all enjoy from being on this land by working, playing, and living here. Thank you, David.
Thank you, Tanya. So today I'm really excited to share some important news about a new chapter for London Health Sciences Centre, one that centers around you, our community. As you know, LHSC has been a cornerstone of healthcare in this region for generations, providing exceptional care and support during some of life's most challenging and joyous moments. Now, as we continue our journey of transformation and progress, it's time to renew our commitment to the people who make this community so special. So starting today and every month to follow, LHSC is going to host monthly community update meetings. These will be live streamed through our website and social media channels, and a recording will also be made available afterwards. These sessions are going to serve as a platform to keep you informed about what's happening within our organization, sharing updates on new initiatives, and also outlining the steps we're taking to deliver on our promise of excellent care. Our aim is to foster a spirit of transparency and accountability, ensuring that you, our patients, families, and community members, feel connected to the decisions and actions that shape the future of healthcare here at LHSC. When the new board of directors is renewed, this transparent platform will continue. In each of these sessions, we will be highlighting the progress of key projects, from advancements in our services and technologies to improvements in patient care and support. We'll also take the time to address your questions because your voices matter. You can find a link to a form to submit your questions on our website and in the description of the YouTube live stream. We'll also share a QR code at the end of the meeting as another way to send your questions. We'll dedicate some time in the next meeting or even before the next meeting to address your questions, and as many as we can. This is an opportunity for us to listen, for us to learn, and to ensure we are moving forward in a way that reflects the needs and values of the community we serve. Our goal is simple: to return LHSC to you, the community, where it belongs, to rebuild trust and foster collaboration so that every step forward is one we take together. We are committed to making LHSC a place that not only meets our healthcare needs, but is also a source of pride for our city and our region, a place where care, compassion, innovation come together in service of all. I invite each of you to join us for these live streams, to share in our progress, to ask questions, to hold us accountable. This is your LHSC, and together we will build a brighter future for healthcare in London and beyond. So thank you for your ongoing support in attending our first community update meeting. Together, we can and will achieve great things. So before we start this month's presentation, I'm going to address a couple questions I've been receiving lately as supervisor. The first one being, when will we recruit a new board of directors and president and CEO of LHSC? I must first comment that this is not a race. Racing to a conclusion sometimes gets organizations in trouble or fails to correct historical issues that got them into a particular predicament in the first place. It took time to get into this predicament. It'll take time to get out of it properly. Right now, the leadership team, which includes not only administrative staff, but also all medical professional physician leadership from the Medical Advisory Committee, and I are focused on strengthening LHSC's management, operations, and financials before we begin recruiting a new board or president CEO. We've already made a lot of progress, and we know there's more to do. Over the past 5 months, we've undertaken 3 major projects as part of this work. Not only did we already make changes to LHSC management structure in my first 5 months, leading to an improved structure with efficiencies and cost savings, but we also are well underway in our benchmarking exercise, a best practice in any business to compare every clinical and non-clinical program to others across the province in an effort to seek improvements, efficiencies, and best practices while prioritizing the quality patient care. That work is being completed, but it is not a one-time and done process. It should be done annually and also whenever a new program or service is created. The results of this work are going to be shared with Ontario Health before any changes can be made, other than ones that relate to administrative areas. In a third and aligned project, as we've recently started what's called a detailed organizational review with the support of a third party and their experts, involving administrative and physician professional staff leadership. This takes benchmarking to the next level. It does a deeper external dive into all of our programs, operations, policies, procedures, management, and more. It's going to focus on things like financial planning, forecasting, monitoring, governance oversight, governance overall, clinical utilization, clinical forecasts, budget processes, staffing models, patient flow processes, working capital and cash positions, policies and procedures, and priority capital replacements and needs. This extensive project will take 4 to 5 months to complete. At the end, we're going to have a comprehensive group of recommendations that are going to strengthen LHSC's operations, governance, management, policies and procedures, and financial planning. This work is being supported by Ontario Health, and unlike other reports that might sit on a shelf and collect dust, the recommendations for this report will be ones that Ontario Health, Ministry of Health, and myself as supervisor will make sure are implemented. This will put LHSC on the proper trajectory moving forward. As stated, governance is going to be a part of the focus of this detailed organizational review. It is not until we get the results of this governance review that we can start to talk about the renewal of the board of directors. Again, we must walk before we run. We must learn from the mistakes of the past and fix them moving forward. We're going to get there, but it's going to take a little time. As stated, it took time to get into this predicament. It's going to take time to get out, but get out of it properly. All hospital supervisions have ended positively for the organization and the community. This one's going to be no different. Another question before I hand it off to the team is some issues that have occurred here at the hospital with respect to volumes and the impact on the organization with respect to some volume issues. And I just want to talk about, we've had some, unfortunately, some increased patient volumes across our 2 campuses, the University Hospital and Victoria Hospital. And when this happens, we call them patient flow challenges because we have a higher than usual number of patients being admitted compared to patient discharges across our clinical departments. So this means we need to look at creating the capacity to care for more for these new patients, which is what we're doing now. So our clinical teams are continuing to expedite all possible discharges in a safe manner to create capacity while prioritizing quality care. So we're calling upon and we're working with all of our local partners. And that's as a result of the fact that we are a center, you call it a tertiary center, is we're doing procedures that no other hospital does. So we play such an integral role in the whole overall clinical capacity of the system, is we're working with our partners to ensure that when patients are done their care at London Health Sciences Center, they go back to their home. They go back to their home hospital for their care. So we're working with the host hospitals with respect to that, while at the same time with our regional partners with respect to subacute services. At this moment, we have not had to postpone any surgeries. That's not to say that that will not occur moving forward, but at this moment, we have not had to do that, and we're able to find the capacity in the system by working together. So I must really thank the frontline staff with respect to the work they've done, the physicians regarding the hard work they do on a daily basis in order to move through this. The last thing I want to talk about is something pretty exciting that we've done, already put into place, and that we talked about in the past. And that is to form what's called a community advisory committee. I'm going to call it the LHSC CAC. The CAC's already had their first meeting last week. It's made up of 10 individuals from our community with rather diverse and rich backgrounds. And they've agreed to donate their time to provide advice to myself and the leadership team at LHSC as we continue on this journey. Here's a list of the individuals, and we've also posted their bios on our website. During our first meeting of the CAC, we've agreed that in addition to their own experiences, in order to get a pulse on our community and Team LHSC, they will be conducting a survey of both the community and our LHSC staff and physicians. These surveys are going to be going out in November, so stay tuned with respect to that. We're going to be sharing more information about the CHC and the work we're doing in the weeks to come. So I really want to now move on to our presentations. And the first one today is going to focus on the upcoming respiratory season, what to possibly expect and what the current situation looks like. I'm going to hand it over to the first presentation to our interim chair of the Medical Advisory Committee, Dr. David Stephen, and Deborah Wiseman, our corporate nursing executive. David?
Yeah, thanks so much, David, and for the opportunity to present today to the community and to the Team LHSC. So, although I'm a neurosurgeon, as David pointed out, I'm going to be talking today about something that affects all of our patients, and that's influenza. We thought we would start we could look a little bit about what's been going on down in Australia, which, as you know, is kind of the opposite of us. So they're at the end of their flu season. And they had, the same types of problems that we would have during flu season with increased admissions to their hospitals and whatnot. You can see here, this would have been last year, back in 2003. I'm not sure if you can see my arrow, but back in 2003. David, can you see my arrow there? No. And then at the end, you can see 2004. Typically, number of admissions will go up, and this is what we can expect at LHSC over the next few months. Is the same thing, that admissions would likely be going up. This year they had a fairly routine flu season. You can look at this green. If you see the green kind of hatched line, that was the peak incidence around, I don't know, somewhere around week 28, 29. Which is around the average for if you look at the dark black line, which is kind of the 5-year mean, more or less falls into the middle of that blob there. So fairly routine. And again, this basically shows the same thing, that the gray area is the average, and the dotted line is the average, and then the dark blue line is the flu season, which is winding down. The other very important thing is to recall that there are certain groups that are particularly affected by influenza. And if you look at this graph, the orange line is patients that are over 65 years old. And the red line immediately underneath it is the opposite end of the spectrum. And these are young children and babies. And we know that those two populations are by far the most vulnerable and the most affected by this condition. And it's important that we remember that for those of us in the lower lines, that it's the people around us over 65 and under 4 years old that are particularly vulnerable when we're around them. Some basic facts about the flu. It's a contagious viral condition. Some people don't develop symptoms, but if they do, it can be very severe, including death. And it's particularly true in those two populations that I mentioned. It usually takes about 1 to 5 days after exposure for people to become symptomatic, and they can be contagious before they're symptomatic. The human infections with avian influenza A are rare, usually occur after close contact with infected birds. And that's not what we're talking about mostly with flu season. Antiviral medications can be used to treat avian influenza, and it's important they be taken as early as possible, ideally within 48 hours. This is the so far the update, and now the numbers in Ontario are going to be low, so because we're just at the start of our flu season here, so we're not going to see a lot of activity. But these are this is a list, the number of bird flocks that are impacted by the avian influenza in the province. So you can see 49 estimated number of birds, 900,000 birds in Ontario. And now we're on to my colleague.
That's great. Thanks. We thought you might be interested in other infectious areas that you might have questions about. So along with avian flu, this is what we would have called monkeypox previously. It's now known as Mpox. This is a rare disease. It comes directly from the Mpox virus. There are two versions of this virus to be aware of, clade 1 and clade 2. The more severe appears to be clade 2. And so far to date in Canada, we have not seen clade 2 surface. The transmission is usually from skin to skin or from close contact, and the incubation period is about 3 weeks. Next slide. It is, as I said, spread through skin to skin or close contacts. It can also be from contaminated surfaces. And if you are traveling to the Western or Central Africa areas, it can also be seen in infected wild animals. Again, to date, no reported cases of clade 1 in Mpox in Canada, and the risk to all Canadians from Mpox remains low. For us, clade 2, apologies on my error on the first slide. For clade 2 infections, you're looking at about 164 cases between January and August of 2024. And most of those cases have been determined to be domestically acquired, meaning that they were locally transmitted. Again, the severity of these cases are low. The risk to our Canadians remains low, and there are rare hospitalizations with no deaths reported from Mpox to date. Next slide. When you look at these graphs, the circle suggests the Americas, which would be the area that we would fall in, and you can see our rates are very low right now as you go towards the right of the graph, and you can certainly see the African region right to our left with the most significant rates of infections ongoingly. Next slide. So if you're looking for signs and symptoms, the first place we ask you to look is, have you traveled to any of the areas that have high incidence of these particular infections? If you have, you can monitor. There's education available on the public health website, so Middlesex London Health Unit. And there's communications and updates ongoingly about the cases locally in Canada and in Ontario. And for us at LHSC, should we come in contact with someone who may require hospitalization, we would do enhanced surveillance, meaning we would be monitoring those cases more closely. Individuals who are experiencing that infection would be placed in a single room, and should they require a stay up to or longer than 21 days, they would be maintained in that single room. Treatment is available through Middlesex London Health Unit, and certainly as a case becomes more severe, we would access that vaccination availability based on symptoms and complications. And should you have any questions or concerns about a possible infection, we would ask you to connect with the health unit. Next slide. This is heading back again to the COVID, influenza, and RSV, so our respiratory illnesses. Just wanting to show in the top graph the percent positivity. So as we monitor infection rates for Ontario, we are seeing towards the right of the graph into September and the beginning of October that COVID-19 positivity is rising. We are not seeing yet a rise in influenza or RSV, but we do expect that. On the left side of the graph is last year, starting in November and through to March, you'll see those higher incidents of those particular infections. In the slide at the bottom, this talks more about hospital bed occupancy. So those individuals who acquire these respiratory illnesses that do require our support in hospital. Again, to the left of the slide is last year's sort of respiratory season. You see COVID really drove much of the hospital bed occupancy with some influenza and RSV occurring. You'll see it as it comes to the right of the graph, which is where we are now seeing those COVID hospitalizations start to climb. Next slide. This slide just gives you a different perspective. The COVID-19 percent positivity you can see between COVID, influenza, and respiratory syncytial virus or RSV, that COVID is our highest positive percent and does drive high bed occupancy. Influenza close second, and RSV, the volume of cases are lower, but certainly we see this higher in our infant and pediatric populations. Next slide. Another graph just of our patient volumes as it relates to respiratory illness. And you'll see within the red circle area, I'm not looking to complicate things too much, but just to advise, you can see we crest anywhere from about 40 to 80 patients staying in our hospital beds with a primary respiratory infection, supporting their needs while they're here during respiratory season. So we're into September now. As we crest into the mid to end of October on the graph, you see that we are expecting increases in our volumes, which David Moucher has indicated at the beginning of the call, we're already starting to see this week. So certainly we've got plans and strategies in play to monitor the patients who require us that don't have respiratory infections as well as those that do. Next slide. Just another perspective, this is Middlesex London Health Unit as opposed to Ontario totals. And again, you can see on the left-hand side of the graph, as we crested last year's respiratory season, the bed capacity that was required to support those individuals who required support with those infections, as well as on the right-hand side of the graph is our emergency department visits. So we do see spikes during respiratory season, and that has started already this year, and will increase through to January, and as it comes down to an end towards March and beginning of April. Next slide. I'm not sure if anybody in the community is aware, but our pathology and laboratory medicine PALM microbiology team were extraordinary in the COVID-19 diagnostic world and have been in that world since the beginning, and certainly sponsoring and supporting much of our regional COVID-19 testing. As the COVID-19 pandemic becomes endemic and becomes more of a routine reality for us, the government will make some changes as we're seeing, and part of that change includes where the testing for COVID will be done for our communities. And so our PALM lab, as we call it, is shifting to testing locally. So those patients that come into hospital will still have testing based on symptomatology, admission criteria, and a few other criteria locally. But in the community, the testing will be sent more towards the provincial laboratories. You shouldn't see any notable difference, and those individuals who have the highest risk will still receive their testing. Next slide. From a perspective of LHSC, should you or a family member require hospitalization and stay for us with a long period of time, so individuals who move past their acute stay to what we call alternate level of care stay, you may be approached to determine whether or not you might like a vaccination while you're in our walls. Additionally, for high-risk populations in nephrology and oncology, so that's our renal and our kidney areas, if there's an outpatient clinic offering that opportunity, you can take advantage of getting vaccinations while you're here for your services. Within our teams, keeping our teams safe and healthy is important in the management of your needs in our community. We do offer stationary clinics starting this week, actually, in our hospital locations, as well as roving clinics. So certainly making sure that our staff have full access for flu and COVID-19 vaccination programming in the hospital. Next slide. What can you do in our community? You can consider getting the updated influenza and COVID-19 vaccinations. They have arrived into our community. So through your family practitioner and through the pharmacy opportunities, you can stay vigilant. You can consider wearing a mask in public, maintaining 6 feet distance from others. Certainly hand washing frequently is a really good strategy. If you don't already have in your medicine cabinet acetaminophen or Tylenol, ibuprofen, those two medications can help for muscle aches should you start to get a fever and or muscle aches. A cough syrup and a thermometer are certainly good tools to have in your medicine cabinet. And if you develop symptoms that you feel require attention, call your healthcare provider. You can speak to a pharmacist. There are walk-in clinics available, and they can advise you on next steps. We've got some links in the slide deck, which will be shared on our website, and you can check out those links for where you can go for those services. We would ask you to stay home. Consider staying home if you're sick, and wear a mask, absolutely, if you do have to go out. Next slide. Onwards to the update meeting.
All right, I'll just jump in there. Thanks so much, Deborah. So first of all, I think we want to thank you for the opportunity to provide an update to the community. We appreciate your interest and obviously your ongoing input. My name is Nash Syed. I'm the Vice President of the Children's Hospital and Women's Program. I haven't seen my picture come up, so I'm assuming all of you could see me, or they see the screen. Perfect. And I'm pleased to be joined by Dr. Rod Lim, who's head of the department and the pediatric emergency physician. So we'd like to start by providing some information about the Children's Hospital winter viral season. Thanks so much for going to the next slide. As Dr. David Stevens suggested, like what we're learning from we'll go back one slide. What we learned from the Southern Hemisphere is that it's going to be similar to what we've seen in the past, which is fantastic. That's a great thing. But we know that we have to stay ready and available because it's not just the flu season that hits us. It's other things. It's trauma. It's surgical volume rises. It's inpatient length of stay problems that we have experienced. So there's a number of things that are important to keep the hospital running smoothly, to ensure that you receive the care that you need when you need it. I would say my belief is that we're very lucky to have a children's hospital here in the western part of Ontario. We've got actually two, but it's because we've got a significant geography, a significant population to serve, and a very different community base of hospitals. So we serve Erie, St. Clair, and Southwest region, but we go as high as Thunder Bay in Northern Ontario, and we go down to sort of the Hamilton border. So we are very fortunate to have the Children's Hospital. A couple of quick facts as I go, and this is it. People may not realize that we have 6,000 babies born. We're the second largest high-risk single-site hospital for birthing in the country. We have 45,000 emergency visits, and we've seen a 28 to 30% increase in the last 2 years. So it's significant. While we post 2.8 hours as the time to see a physician, if you go on our website, you'll often see it's 3/4 of an hour, 1 hour, 30 minutes. So we're very pleased by what Dr. Rod Lim is able to do with his team down there. 800 critical care visits. Please remember, we're one of 5 critical care sites for pediatrics in the province, which means we have to keep activity and beds available. Mental health has been a big priority, and we've been doing a lot of work there. We're very proud. The ministry just gave us a 3rd pediatric transport team. So that allows us to manage flow when you need to either come into the hospital or leave from the hospital. A couple other facts: 54% of our activity comes from outside London, Middlesex, and so we serve a very large region, and it's important to keep that capacity. And the last thing is we've been able to reduce our surgical wait list by 1/3 in the past 18 months, and we will continue to do so you can have timely access to care. I'm really now pleased to turn over to Dr. Rod Lim to provide some insights and thoughts. Rod?
Thanks so much, Nash. I reflect on this presentation, and I think, there's lots of things that always stay the same, and there's lots of things that change. And I think anyone who's a parent out there knows that respiratory season comes when the weather changes. And it's really hard to keep your kids healthy and able to go to school and do the activities that they love. We're so fortunate to work with the team that we work with. We anticipate viral season every year. And I'm so proud of our team that really goes above and beyond to try to use every resource available to be able to provide need not only here in London, but also, as Nash said, throughout the region. I was able to attend a meeting with our Chief Medical Officer, Dr. Moore, and really forecasting that we are returning to anticipated viral season loads this coming winter, with a peak around the holiday time. And that looking at the Australian data, the one thing that is slightly different is that pediatric hospitalizations were up. So we are anticipating that this will luckily not be as bad as a couple of years ago, but still challenged in terms of making sure that we're able to provide the type of care that we strive to do. One thing I do want to say that is different is the amount of preparedness and our plans with working within the region for flow of pediatric patients to the right place at the right time, and also for people to know how to respond in the moments when we have those capacity challenges is very different than in my experience in the past 20 years working here in the pediatric emergency department. It's a fantastic team, and I think the plans that we have laid out are really well thought out. The second thing that is quite different is I think Ontario is being very proactive with its RSV strategy, especially in infants. You might have heard it announced through public health or through the government, but any child that's born this year is eligible for the monoclonal antibody called nirsevimab. You should have heard about it if you have a baby that has been born this year, but if not, you can access that through your primary care physician or through public health. If you have a high-risk child under the age of 2 at Children's Hospital, we are there to provide that vaccination protection for you. Studies seem to indicate that it prevents hospitalizations up to 80 to 90%. So it's extremely effective. And I really applaud our province for being proactive and kind of ahead of the curve in offering this to the public. So I hope that people avail themselves of that. I'm going to turn it back over to Nash to go over some of our local strategies.
Great, Rod. Thanks so much. We'll stay on this screen slide if that's okay. So with winter viral season just upon us, we continue to do things to really make your journey sort of safe and smooth. That's not only for the patients and the children we serve, but also for the families. So just a couple of reflections. First, as you enter the emergency department, we've done work to increase our capacity, whether it's putting chairs in there instead of stretchers. We're working with the ministry to increase our capacity in terms of actual emerge stretchers. We've really put a mental health team down there, which is a social worker, child youth support. We've seen an incredible increase in the number of mental health coming through our emergency department, and we know it needs a different type of care. So that's been a big focus. We are, thanks to Dr. Lim, we're one of the virtual urgent care sites, the only virtual urgent care site for pediatrics in the province. And we're hoping to sort of expand that. And our clinics are running evenings and weekends now, specific clinics, so that we can keep up with the demand. We can go to the next slide. As you progress into needing an inpatient bed, if you do need one, we're working with the Ministry of Health to secure capacity to beds. Specifically, we've had 5 more additional beds, which is significant because our bed base was around 60. So if you can imagine, we've increased our bed base by about 12.5%. We've also been fortunate to have investments from the ministry to increase things like patient care facilitators, oncology nurse managers, nurse practitioners. We've got to have the right level of skill around the patient. So that's been a very big focus. And we're working on new processes. So where you don't necessarily need to come in and be admitted to the hospital, chemotherapy infusions, that's been a major area of focus so that we can best utilize the resources and be available when we're needed for bedded capacity. If we can go to the next slide. We've also expanded our critical care capacity. We are one of 4 major pediatric critical care sites. So our beds are managed provincially. They watch it. If there's something new in Ottawa and Ottawa is busy, they would send them down here. So We are getting ready to open up our high dependency transition unit. Those are lower level critical care beds that are needed. So we're going to open that up again right now. And the beauty of that is, as Rod said, we've now gotten better with our processes. So not only can we do it quicker, but we are now going to have capacity to admit 24/7. We've been working with our medical staff and our residents to really create a fine-tuned process to best utilize those beds. We put in a new surge level system with colors on it so that we know across the entire children's hospital, and communicating with LHSC what is our surge level so that we can react, because it's not just the emerge or critical care that runs into trouble. It affects us all because we're interconnected. And as I mentioned before, the ministry funded us with a transport team. And that's critical for moving patients between our peer hospitals and inside and outside of our jurisdiction. And if we can go to the last slide, I think it's really important, being a children's hospital located within a region. It's really important that we recognize that we don't exist without our peer hospitals. And that is not only hospitals, but also our community agencies, Ontario Health West and our Ministry of Health. So we literally have a daily touch point every day, and it's been continuing. When surge came down, even over the summer, we've maintained that 11 a.m. call to manage surge. The other things that we do is we work really hard with our pediatric hospitals in our community to get patients here when they're needed, but also to get them back. And we've instituted a new process where we communicate with families when they come to our inpatient units, especially during surge season, that we may need to transition you back to your home hospital that's located in your community. It's good for families to receive the care, and our job is to make sure that you transition properly, securely, and safely. So we are making sure that our communications include that. And we worked with our patient and family advisors to build that communication. So we're hoping it is patients centered. But if you have any concerns, please let us know. We're also working with our community partners to make sure that we're investing in the right spaces across our system. And so, because we believe that being a children's hospital, it's not just about what's at the Victoria Hospital campus, but it is a pediatric system of care across our regions, including Erie, St. Clair, and Southwest. And we're pleased to be very fortunate to offer some unique services to children's, like our clown, like our child life, like our art therapy, music therapy, which is what makes us special. So we're very thankful for that. So I'd like to hand it back to Rod for some closing remarks.
Yeah, and I'm just really struck by, I love metrics and other processes, and I'm very proud of our metrics. I'm proud that we have the best physician assessment times in the province. But that's nothing if there's not a good patient experience. And a lot of times patient experience is not only good quality care, but it's how you're treated and how you're respected, and whether we're able to allay those fears. And I just want to say that I'm just really, really impressed by my team, the people I get to work with all the time. And I think despite it being a very challenging time to be in healthcare, we really try to keep that forefront in our mind, because we also know it's a challenging time to be a parent. And we know that coming to a hospital is an incredibly scary experience, no matter how many times you've come. And that we really strive to make sure that not only can we adapt to the pressures of a viral season, can we make sure our processes are efficient to keep everyone safe. We also want to make sure that your experience is an excellent one, where we respect your child and are aware that it is a very scary thing to see someone like myself or my team. I also want to thank the community for their incredible generosity. We have had incredible gifts to us, and they can be something as small as just the thanks for the experience or whatnot. And I just want to use this forum to reach out and say we really do appreciate that. We see the heart that you give to us, and I think this is a great forum to show our appreciation for that. So thank you very much as well in the community.
I think with that, I think the update from Children's Hospital is complete. We'll hand it over to the next speaker.
Good afternoon, everyone. I'm Kathy Vandersloos, one of the clinical vice presidents here at London Health Sciences Centre. Today, I'm joined by our two physician lead colleagues from Anesthesia, Dr. Noppins and Dr. Nicolau. If we could move to the next slide, please. just briefly introducing the programs that I represent. I'm accountable for most of the surgical programs here at London Health Sciences Centre, including what we call perioperative services, which are operating rooms and our recovery rooms and everything that it takes before and after preparing you for your surgery. That would include our Nazem Kadri Surgical Centre located opposite Victoria Hospital. I'm also accountable for specifically the cardiac surgery and our cardiology program, our multi-organ transplant program. We're one of 2 multi-organ transplant programs in the province that we're fortunate to be able to offer donor organs to kidney recipients, liver recipients, heart and kidney pancreas patients. And we've been in that business for over 30 years. I also have the pleasure of representing the quality team, patient safety and performance. We're accountable for working with all of the clinical programs across London Health Sciences Centre in meeting quality standards, patient safety standards, including accreditation, basically keeping patients safe and staff safe to the best of our ability. And we have a lot of very skilled team members working, as I say, alongside all of our teams across LHSC. And lastly, all of the health disciplines representing here. Some of these are care team members that you may have worked with when you've been at London Health Sciences Centre, who are integral parts of our care team. We work with them in not just what it is that they need to do clinically, but also maintaining practice standards and making sure that they are meeting their requirements from a practice perspective. Next slide. I'm going to turn it over to Dr. Noppens, who's going to walk you through a few slides, and we're going to pivot a little bit. We've talked a lot about how we're trying to keep you safe in respiratory season, and what we're going to talk about is our team members, anesthesia, who keeps you safe during your surgery, but also we're trying to do our best to maintain, as David Moucher said, your access to surgical care, because many of you would know that there are long wait times, but we are making considerable strides in being able to knock that down, not unlike what Nash said in the pediatric slide. So without further ado, I'm going to turn it over to Dr. Noppens.
Thank you so much, Kathy. Much appreciated. Hello, everyone. Thanks for joining this afternoon and spend some time with us to listen what's going on. We thought we'd speak a little bit about anesthesia because this is one of the more highly thought after jobs in the province, simply because anesthesia is a cornerstone for getting your major surgery. So overall, what is an anesthesiologist? Well, it's a doctor that helps to keep you safe during surgery, comfortable. So not just putting you asleep, but also waking you up again and have you as exposed to as little side effects as possible after your surgery. So you will meet the anesthesiologist right before your surgery or days ahead of your surgery to discuss your physical state, the type of anesthesia to expect. And you will meet us in the OR to give you some oxygen to breathe, some great medication that's going to put you off to sleep. Sometimes we just give a single injection in body parts to numb them down. It's called a block or a spinal anesthesia. So when people go numb in the lower part of their body. We monitor vital signs during your procedure. And the good news is we're not just watching, we're also treating. So if your vital signs are off, we have a range of medications ready to make sure that everything goes back to normal. And after surgery, we help people to wake up and feel as good as possible. Some really enjoy the experience, I hear. We also take pain away directly after surgery. And some of our chronic pain specialists are involved in treating pain for the poor individuals who experience chronic pain. So a lot of people describe the job of an anesthesiologist as of being a pilot. So when you go to the OR, there is this preparation period. So when you walk to the Galway, you know, and you find your seat and so on, that's the preparation phase where you meet the team, you're getting brought in the OR, and the immediate takeoff preparations when we have you on the monitors, we check your ECG and so on. And the takeoff period is when you breathe some oxygen, you get the medication, you get numb and, you know, dizzy, you drift off to sleep. Then we have the in-flight period, which is for us when you have your actually surgery. and the surgeons doing their phenomenal art and job. And then the landing period is when we bring you out of the anesthesia to have you a soft landing, as soft as possible after the procedure, to have you slowly and comfortable waking up. And then the rolling out into the terminal is when you find yourself in the recovery room. There has a lot of talk been about there's a shortage of anesthetists in the province, which is completely true. But however, I'm very happy to say that somehow we managed to be in a very comfortable position. We are over 100 anesthesiologists at LHSC. And we also not just serve the university and the Victoria campus, but also St. Joseph's Hospital and other community hospitals, by example, Chatham or Sarnia. So how to become an anesthesiologist? Now, obviously, you watch this like, oh, I want to be an anesthesiologist. Well, I tell you, it's a long and rocky way. We're talking 12 to 14 years step by step. I've shown you through step by step. Yeah, if some kids are listening, your parents going to turn pale seeing that what's involved. So you're looking into undergraduate periods over 3 to 4 years. And usually subjects chosen are around biology or chemistry. Then it's a very, very competitive to get into medical school, which is another 4 years, which basically teach you to be a doctor. That does not involve like how to be subspecialized, let's say in family medicine. That would be addressed in a so-called residency. And the anesthesia residency is one of the most thorough in the world because it involves 5 years. Many other countries have a much shorter program. But in Canada, we're having, and I'm very proud to say that, one of the best programs in the world. You're not done after. A lot of people after that training would be willing to go into smaller hospitals, into the community. However, the individuals who decide to stay on in tertiary centers, so big, large hospitals that offer a wide range of care, will decide to take a fellowship to subspecialize in specific fields like pain, as I mentioned earlier, in acute or chronic pain, or in liver transplantation. So you spend another year in learning how to help patients while they undergo a liver transplant surgery when they receive a new organ. Obstetrics, like, yeah, help to deliver babies. Very cool. Brain surgery is another one. So like what to do to help the surgeon to succeed during awake brain surgery. Some of them probably saw the videos where somebody placed a violin. So anesthesia is involved there as well because it's not that simple. So get people to the sweet spot. So that requires the expertise, pediatrics, cardiac surgery, as well as some of us decide on a intensive care pathway, meaning helping very sick patients. So where do we work? We're all over the place. So you will find us, I'm starting on the right, in the post-anesthesia care unit. So when you wake up and despite our best efforts, you don't feel so good. The nurse might actually call the anesthesiologist to help to make you feel better, treating pain, nausea, and so on. You will find some of us in the intensive care unit when you're where very, very sick people are that need specific treatment, ventilation, artificial ventilation, life-saving procedures, and so on. Operating room is where you will find us most often. And that's our main job, to facilitate surgeries and to make some pretty crazy stuff happening. You will meet us in the pre-admission clinic when we talk about your upcoming procedure, where we check if there's additional tests needed to keep your surgery safe. And we're part of a team, including medicine, to come up with the best plan to keep you safe and identify potential other tests and interventions that are needed to bring you successful to surgery. You will find us another area, dental offices, endoscopy. So most times when propofol, when you hear propofol is at play, that's a more deeper sedation. An anesthesiologist and an anesthesia assistant will be present to help you through that. And I hear people are all over the moon when they had propofol. Okay. Science research is another part that we cover. So interesting enough, we have a number of individuals that belong to the top 5% of publications in the field of anesthesia in the world, not just Canada. So we have outstanding scientists and researchers that look at a range of problems. We're involved in teaching, medical students, our residents, other residents. So we have ENT residents, ear, nose, and throat, as well as emergency medicine residents rotating through our area, where we help them, acquire some of the skills that we have and show some of the tricks that we use to place this breathing tube in, and so on and so forth. And I mentioned, obviously, pain clinics. Next slide, please. Thank you. So I just want to really, really quick touch on some recent advances in anesthesia, and part of that is EEG monitoring. So when you wake up and it looks like a squid attacked you at the forehead, these are the residues of some EEG electrodes that we use to look how deep your sleep is, to make sure that you not accidentally wake up and not to give you too much of anesthetics. There has been recent advances around video laryngoscopy, meaning there's specific tools that can be used to place this breathing tube, very successful on first attempt, so not multiple attempts, like first time go, simply like as safe as taking off and landing a plane. We in London have been one of the first publishing that area and have helped to shape the field in the world. There have been medical improvements, like reducing problems with delirium, which is also a team approach that's right now going on, some research around the area, as well as addressing nausea and vomiting after surgery. So I want to finish my talk with the words, I hope you did not fall asleep. Then I probably would have done a great job with putting you to sleep, but a bad job of entertaining you. So thank you.
Oh, Dr. Noppens, thank you so much. Appreciate your enthusiasm and passion for our anesthesia team and how they contribute. I see a very strong pipeline of anesthesiologists in our futures, thanks to your talk. And thank you to everybody for joining. I'm going to pass it over to my colleague, Tammy Quigley, and leave it to Tammy. Thank you.
Thank you both, and good afternoon. Always a tough act to follow, Dr. Noppens. My name is Tammy Quigley, and I have the privilege of leading areas in cancer, renal, mental health, and patient flow. And I'm joined here today by my physician colleague, Dr. Mohammed El-Fakani. Dr. El-Fakani is a psychiatrist who's been at London Health Sciences Center for over 14 years. And today we're just going to provide a really brief overview of the mental health program. Next slide, please. In setting the stage for our very short presentation today, I just want to acknowledge the impact that mental illness has on so many of us. It is significant, and our programs and services here at London Health Sciences Center really work to ensure wraparound care for our families and for our loved ones. Mental illness affects people of all ages, education, income levels, cultures, and we know that there are systemic inequalities such as racism, poverty, homelessness, discrimination, colonial and gender-based violence, among others, that can worsen mental health symptoms of mental illness, especially if mental health supports are difficult to access. And of course, when you think about life-saving things that happen at London Health Sciences Center, you might think about trauma, you might think about some things that happen in our cardiac programs, maybe stroke. You might not necessarily think about mental health, but the reality is our teams here are actually saving lives as well every single day. I'm going to turn it over to Dr. El-Fakani, who's going to talk about some of the programs that we have here at LHSC. Dr. El-Fakani?
Thank you, Tammy, and David and the rest of the team helping organize today. I really appreciate us having the opportunity to present to the community some of the great work happening in mental health and addictions treatment at LHSC. This slide is a bit tricky because it has a bunch of animations, so feel free to just go next slide a few times maybe. Yeah, so I'll start with there. We are I think one more maybe, and then we're good. Yeah, thank you. So we are a Schedule 1 facility. And what that means to people is that LHSC can admit people involuntarily. And what that means is without their consent. To be admitted involuntarily, a physician must determine that a person meets the criteria under the Mental Health Act, like essentially that they are a risk to themselves or others. But it is a responsibility, and we are a Schedule 1 facility here at LHSC. We also take a very multidisciplinary approach to treating mental health. There are a lot of different team members from various backgrounds across outpatient, inpatient programs. These include psychiatrists, social workers, psychologists. We have nurses, we have orderlies, we have occupational therapists, we have dietitians. And so it's quite an interdisciplinary team. And in almost every facet of someone's experience at CMHA, at LHSC, you will encounter a team-based approach. So that's really, really important to us. We also, we are a large place as well. We are one of the biggest mental health facilities in Ontario. We have 105 beds, and you can see a breakdown there of a couple specialty units that we have, including a psychiatric intensive care unit, a short stay unit, geriatric behavioral unit, specialized care unit, and then some regular beds as well. So I've been at meetings, like regional meetings in Ontario, where I've mentioned we have 105 beds and people gasp, like, this is a big place here at LHSC for sure. We also help individuals who are admitted under other services. So people admitted under medicine or surgery may require general psychiatric consultation service. So we do that in the hospital, both at Victoria Hospital and University Hospital. And we also offer a fantastic addiction medicine consultation service, along with our colleagues in medicine and those in family medicine. We help support any patient in the hospital, not just under mental health, but on other floors as well, who are struggling with addiction issues as well. And we're also, psychiatry is also embedded in our emergency department through a service called the Centralized Emergency Psychiatric Services. And what that means is that we have an office downstairs in the emergency department, and we have a team of psychiatrists, nurse practitioner, psychiatric assessment nurses, and social workers that help patients who present to the emergency department, again, embedded in our emergency department. In adults and geriatric mental health, we have close to 35 psychiatrists now, in addition to all the other team members, and we've been able to recruit really well over the last several years, which has really helped us deliver the services even better. Next slide. Thank you. So I'll focus here a little bit more on inpatient services. And here are some of our stats. So we get around 869 average emergency department visits per month. So around 11,000 visits a year to the emergency department. And I know this is labeled inpatient services, but we're talking here a little bit about what leads to an inpatient stay, which is through the emergency department, typically. So around 869 average visits per month, around 49 patients a month. Again, these are average numbers, are able to be diverted to our partner, Canadian Mental Health Association. We really work to leverage our partnership with CMHA, the Canadian Mental Health Association, and the community, where we are able to divert some patients who present to the ED but are more appropriately treated in the community. So that happens also. And we end up admitting around 271 average admitted patients per month to our inpatient units. And we average time to get from the emergency department to a bed is about 18 hours. And this is an area we've been working on quite extensively. We do a lot of work to try to improve the time from ED to a bed on the wards. And in the upcoming months, you'll hear a lot more about this and how we have shifted this time from, it was really upwards of 100+ hours to now, on occasion, it being less than 10 hours. But we're averaging around 18, and it depends on which unit the person's going to. So to our psychiatric intensive care unit, takes a little bit longer. A short stay unit would be a little shorter. But again, we really actively work on that time to get people out of the ED and to a room. As with most hospitals, well, not most, but all hospitals, not uncommonly, we do measure readmission rates within 30 days, and we're at about 26%, comparable to other hospitals in Ontario. And again, in inpatient services and in our emergency department, we have a very much a multidisciplinary approach to care. Next slide. So now in focusing on our outpatient programming, I'll provide a bit of a broad overview here today. There's a lot of detail, and this could be a whole presentation on its own. But our outpatient program serves primarily those in London and Middlesex County. usually between the ages of 16 and 64 for adults. And then we have a geriatric mental health service as well that serves above 65. And we also have an outreach geriatric service as well. We have around 51,000 visits with outpatient mental health per like in the last fiscal year. And those are about 9,500 patients across a number of different programs. So this is a very, very busy place, both on the emergency inpatient side as well as in the outpatient side. There's a lot of great work happening. A few of the specific areas you can see there on the slide, we have a centralized access point. The centralized access point is the main entry point for community referrals to access mental health care. So, for example, a family doctor in the community wants help with a patient of theirs to be seen by specialized mental health services or psychiatry. They will refer to that centralized access point, and patients are diverted to London Health Sciences Centre or, in some cases, St. Joseph's Healthcare London as well. But it's a centralized point for the City of London, so it works well that way. We also have our general adult ambulatory mental health services. So this is essentially our general outpatient services for adults, and these are patients that are seen in these clinics that are typically discharged from inpatient floors or referred from the community. We also have non-urgent versus urgent services within the general adult ambulatory mental health services. So urgent services aim to see patients within 1 to 2 weeks versus the non-urgent pathway. So that's also a service that we help maintain. We also have a number of different group services, day treatment programs like Track to Wellness, interpersonal therapy, cognitive behavioral therapy, as well as emotion regulation, interpersonal skills programs as well. So lots of group therapy that happens as well. We also, you'll see there, Behavioral Supports Ontario, BSO, and Geriatric Mental Health. This service provides interdisciplinary outpatient assessment of individuals who are above the age of 65. And we also have reach out into long-term care facilities in London where we support as well. We're also very proud of our prevention and early intervention program for psychosis. This is a community-focused mental health program that has a mandate to work with individuals who are early in their psychosis diagnosis in their first 3 years. And it's a very much a psychosocial approach in addition to the medication management. There's a lot of support from social workers and nurse case managers to help integrate people into the community well. We also have an adult eating disorders program in the community and a first episode mood and anxiety program in the community. Both of these are situated in the community and serve a very significant population. Both these programs are very evidence-based, and there's a lot of research that happens, particularly within our first episode mood and anxiety program, serving youth with anxiety and or mood disorders between the ages, I believe, of 16 and 25. So there's a lot of work that happens there as well. Thank you. Next slide. I'll hand it back to Tammy. Yeah.
Thanks, Mohammed. I think you've done a great job of really explaining the depth and breadth of programs and services that we provide in the mental health and addictions program. Briefly, I think, and others have mentioned this as well, as part of being an academic health sciences center, we are responsible for training the healthcare providers of the future. And so in the mental health program, we train doctors and nurses, research assistants, psychologists, occupational therapists, and even dietitians. We also contribute to our research mandate, and you can see on this list some of the really interesting research projects that are currently happening within our program, everything from the impacts of COVID-19 on adult mental health to some work on schizophrenia. Next slide. Finally, we wanted to share a little bit of something that our team is really, really proud of. Earlier this year, we took a number of steps to ensure really a safe and welcoming environment for our Indigenous patients, including using an Indigenous navigator role. We have visits from Elder Tracy White-Eye. We've also made use of some space. This used to be a storage room up on one of our inpatient units. This is on B7. It's not quite finished, but we included it anyway. There will be some murals coming in future. But this was really a lovely space for patients and staff to spend some time. They can participate in smudging in this room and meet with elders. We're also in the midst of co-designing staff training with our navigator and our elder. And we've partnered with the Southwest Ontario Aboriginal Health Access Centre, or SOAC. For us, these are really important steps on our journey to and our commitment to truth and reconciliation. Next slide. Finally, we just wanted to end our presentation with the words of one of our patients who's given us consent to share this with you. And as I said off the start, you sometimes don't think of the mental health program as life-saving, but this is a patient who came to us in September of 2022 after attempting to take her own life. And you'll see that she's reached out to us and noted that she had a special staff member sit down and talk to her, use some grounding techniques, and really display the empathy that she was in need of. And the impact of that nurse really did save her life, and she was so grateful to us. And so we're grateful to have that feedback, and just wanted to share her words with all of you. So thank you. Appreciate you staying tuned in, and I'm going to hand it over now to my colleague, Jerry Plastino and Dr. Narinder Paul. Over to you.
Thank you for that, Tammy, and thank you everybody for the opportunity to share sort of a high-level overview of medical imaging today. And as Tammy mentioned, my name is Jerry Plastino. I'm the Vice President for Clinical Diagnostics, Pharmacy, and Biomedical Engineering. And I'm joined by my esteemed colleague, Dr. Narinder Paul, who's the Department Head and Chair for Medical Imaging. Next slide. So before we jump into medical imaging, I thought we'd give an overview, sort of just the portfolio as a whole, and what is clinical diagnostics. And so clinical diagnostics is medical imaging and pathology and laboratory medicine, which we reference as POM here at LHSC. And so the portfolio outside of clinical diagnostics includes pharmacy and biomedical engineering. And again, these are corporate-wide programs that support all the day-to-day needs for all of our inpatient and outpatient needs. They are subspecialty programs, and again, we'll speak to that subspecialty with imaging today. But just some key facts about the portfolio. We have over 1,100 staff across these services, which is a large team, and just speaks to the complexity of care that we're offering here. Before ministry funding, again, we speak a lot about money in medical imaging, and POM is just because of the equipment that we use, the consumables, the supplies. So before ministry funding, we spent over $300 million in this portfolio from an operational expense. Besides the sort of the day-to-day sort of operations and the dollars, they said each of these programs are very significant in terms of their academic and their research output, and we work very collaboratively with all the services across LHSC. And the last thing I'll just mention is biomedical engineering, again, is one of those key services that is crucial to supporting our equipment. They ensure that we meet all those relevant industry and regulatory standards on how that equipment operates. Next slide. So again, our focus today is just going to be on medical imaging, and I'll speak to the team next, and then we'll pass it off to Dr. Paul. Next slide. So who does this work in medical imaging? We have over 409 staff and physicians. So medical radiation technologists, which is my clinical background, are the individuals that are performing your x-rays, your CTs, your MRIs, your interventional radiology exam, and your nuclear medicine tests. In addition to that, we also have ultrasound sonographers or diagnostic sonographers. We have nurses that are embedded in the day-to-day care in terms of the monitoring and support of patients pre and post procedure. We also have individuals, because from a regulatory perspective, there's lots to do with from a radiation safety lens and professional practice, and we have 3 dedicated individuals that ensure that everything we do from a radiation perspective is operated under the strictest guidelines. We also have 63 administrative and corporate professionals. These would be the individuals that are booking, calling, scheduling your tests, meeting you in the reception each and every day, making sure that you have a great experience here. 15 leaders across the board in terms of the program. And then what I really wanted to highlight is our physician group and our residents and our fellows. I think a lot of people sometimes may not understand sort of the subspecialty practices that do exist in medical imaging. So we have these subspecialty trained physicians called radiologists or molecular imaging physicians, we're not just reading pictures, they're actually providing diagnostic interpretations of those images. They also perform therapeutic and minimally invasive procedures. A lot of times, as they get worked up for whatever diagnosis, again, they'll do biopsies, interventional procedures to, again, avoid inpatient visits. And so we play a crucial role in that day-to-day care. Again, their expertise covers everything from neuro, cardiac, chest, body and breast imaging, musculoskeletal, pediatrics, interventional radiology, and molecular imaging and theranostics. So that's just a high-level overview of the skills. I'm going to pass it off to Dr. Paul, who's going to speak to us more about sort of the volumes, the technology, and some of our key innovations. Narinder?
Thank you, Jerry, and thank you, everybody, for joining us, and also to my colleagues to highlight the special things that are going on at LHSC. And because every single program we have at LHSC is really, really busy, whether it's neurosurgery, neurology, cardiology, cardiac surgery, oncology, etc., we get really busy because we see all of their patients or a number of their patients for imaging. So the way it works is that a physician or a family doctor may see a patient and be concerned about something that's going on in their body, and they'll send a request into medical imaging. That request is looked at by a radiologist or a nuclear medicine physician to make sure there's adequate details so that we know what the question is, that we make sure that patient's going to have the right test done in the right way and at the right time. And that's why we need all of this equipment. So CT, ultrasound, molecular imaging theranostics, or used to be called nuclear medicine, X-rays, MRI, and interventional radiology, because what is needed by a 4-year-old is different from a 20-year-old, is different from an 80-year-old, depending on the sort of concerns that are going on. And once that request is seen and approved by a radiologist, it is then what's called protocoled. Then you'll make sure that test is performed in a certain way to give the right diagnosis for that particular patient. And then the most important part is when the patient comes in, our technologists and our nurses make sure that when that patient comes in, whatever has been set down is performed in a way that it's personalized for that particular patient. Because again, patients are at different physical capabilities. They may be nervous. They may be a frequent flyer. So our technologists and our nurses do a tremendous job to make sure that the patient's in a right sort of state of mind to be able to have this examination performed. The examination is performed, and then it's supervised, and the images are read by a radiologist, and then a report is issued to the referring physician to make sure that they have the information that they require. So you can see why we kind of need different pieces of equipment to answer different questions. So if we can go into the next slide. We've been making real progress in the medical imaging department over the last few years to be leaders in Canada in many, many spheres. And I'm just going to highlight a few of these things. So if you go from left to right, we're the first in Canada to have a special kind of MRI. It's called a 0.55 Tesla. The Tesla refers to the strength of the magnet. And if you see that picture, some of the highlights of why it's so important. This magnet was built for underserviced patient populations. So we have 1.5 and 3T Tesla magnets, which are seen in many academic health science centers. But the opening for these standard magnets are 70 centimeters. Now, if you're claustrophobic, that's possibly not enough. If you're larger than average, that's definitely not enough. So for patients who have claustrophobia or who are bariatric, we provide this MRI to be able to do many of the things that we need to do. We've also looked at using this magnet to specifically address the needs for outpatients, because we know that healthcare is delivered on a priority basis, but the problem is, as the difference between capacity and demand continues, the people who have been on the outpatient wait list continue to wait longer and longer and longer. So we've actually focused this particular magnet specifically on outpatients. We're also leading and co-leading with Hamilton a centralized intake process to work with the 28 hospitals across Ontario West to look at CT and MR images and exams that can be done anywhere to balance the wait time so that patients who could have an exam performed at any of these hospitals have it performed at the hospital which has the shortest wait time and is closest to their hospital. So we've done some LHSC and St. Joe's were the pilot sites to see if this would be something that would work and resulting meaningful reduction in wait times. And that pilot was so successful that we're looking at now getting funding to actually roll it out across the whole province. So there's a lot of exciting and innovative things going on there. Jerry mentioned the interventional program. So we don't just do diagnosis, we also treat. So one of the programs that we are leading in Canada is what's called the Y90 training program. So patients who have inoperable liver cancer, for which there's no other way forward, our interventional radiologists put a tiny, tiny tube into the blood supply supplying the tumor, and they'll inject tiny radioactive beads directly into the tumor. And that's a form of internal radiotherapy, which doesn't cause any harm to the rest of the body, but actually treats that tumor. And we've shown that that results in meaningful extension of life to many of these patients, and some of them then can have transplantation, liver transplantation. And we're so good at this, we've actually taken on another responsibility of an academic science center, which is out of education, and we've trained 6 centers around Canada to be able to do this program and make it available for their patients in their local sites. And we do a lot of this in terms of developing innovative techniques, then training other people how to do it. And lastly, we are in the process of replacing all of our equipment. Just like if you have a cell phone, you don't keep it for 20 years because the performance degrades. It's the same thing with imaging equipment. So we've been supported by our board, our CEO, and our foundation to replace all of our CTs, our MRIs, and our angio equipment. So we have the latest, greatest state-of-the-art technology you could find anywhere in the world. And we've developed academic relationships with the companies that supply those to do research and have scientists working with us to develop the next generation of this equipment. We still have opportunities to replace the rest of our equipment, but clearly these things are not cheap, as Jerry pointed out. And so we work with our administration to continue that conversation. And next slide, please. And with that, that's our roundup of medical imaging. It was fast and furious, but if there's any questions, I'm sure we'll be open to address those at any time. So thank you.
Thank you, Dr. Paul, and really want to thank everyone for attending LHSC's first community update meeting. I hope you have found it informative. As stated previously, LHSC belongs to our community, and we're going to continue to engage with you and ensure your perspectives are part of our planning and decision-making processes moving forward. So I truly look forward to connecting once again with all of you at our next meeting, which is scheduled for November 20th. And we also want to hear what questions you have for us. As mentioned earlier, you can find a link to a form to submit your questions on our website and in the description of the YouTube live stream. And there's also that QR code on the bottom right of this slide. Please take a snapshot of it and click it and link to it. And that's an area where you can ask questions as well. And again, we're going to spend time at the next meeting addressing as many of the questions as possible as we can, and or between the meetings, depending on the urgency of the question that's being asked. To our media partners, please join the link to our media scrum, and we'll be there with you in a moment. So again, I really want to thank the members from Team LHSC. It really shows you how much pride there is among the team members here at LHSC, both administrative, clinical, physicians, all professional staff, regarding the care they provide. And as we've stated over and over again, that's not why I'm here. The care is exceptional. Why I'm here is to deal with governance, oversight, financial management issues, and at the same time supporting our clinical leaders. So again, thank you for our clinical leaders, for our clinical teams, for our frontline staff, for everything they do on a daily basis to take care of the patients, not only in this community, but the region, the province, and beyond. So thank you, everybody, and we'll talk to you soon. Take care.